Good morning. Good Saturday morning to you. This is Philip Chapman. I'm Vice Chairman of the ASHNR Education Committee, and part of my duties in that role is to help organize the Case of the Day posters for the annual meeting. This year, obviously, we've converted to a slightly different format, and we thought on Saturday and Sunday morning we could have an opportunity for the presenters to actually put together a 5 or 6 minute video of each case and discuss the case from their viewpoint and explain why they thought this would be a challenging and interesting case and maybe just a fun case for the participants to test their skills, so to speak. Now, COD, we've obviously manipulated the abbreviation here to form the mascot. I don't know if this is a permanent mascot or not, and I don't know if this is a Pacific cod or an Atlantic cod, but this was the brainchild of Dr. Christine Glastonbury. So maybe next year we'll have a contest to actually name the codfish here. I don't know, Hootie and the Codfish, or some. We'll have to come up with some cute name here for this mascot. But nonetheless, this year we had 9 cases presented, 3 on Wednesday, 3 on Thursday, 3 on Friday, and we had, let's say, approximately 9 different presenters. We had a couple of people that double teamed a couple of cases, and you'll see that manifested in the exhibit as well as in the presentation. And you may even see an odd character given some of the video presentations that you may be familiar with. But here are the initial 9 or 10 presenters: Benjamin Gray, Katie Traylor, Benjamin Kwan. Jay Song actually teamed up with Victor Babatunde to present case number 4. Gagandeep Chowdhury from UAB was the presenter of number 5. And then we also had Jenny Soon, Kavya Murchia, Charlotte Taylor, and Amit Mahajan. And so for the next 30 minutes or so, we're going to have the first 5 presentations for the case of the day, and we're going to begin with Dr. Benjamin Gray from the University of Indiana. And then tomorrow, at the completion of these 5 presentations, tomorrow we will return and do the last 4 presentations for the case of the day. So thanks for joining us. Hope you enjoy the next few minutes.
Hi there, folks. Thank you, everyone, for tuning in to learn about the case of the day I presented here for ASHNR 2020. My name is Benjamin Gray. I am newly joined faculty with the Department of Radiology and Imaging Sciences at the Indiana University School of Medicine in Indianapolis, Indiana. I would like to first thank Dr. Chapman and the program committee for giving me the opportunity to present this interesting case. Moving on to the case itself, we have a 41-year-old gentleman presenting with hearing loss and chronic renal disease. Ultimately, CT of the temporal bones was performed. On the top left image, we have an axial CT centered at the level of the ossicles. Bottom left image is an axial CT centered at the level of the cochlea. Middle column, top image, is an axial CT centered at the level of the eustachian tubes. Our middle column, bottom image, is an axial CT centered at the level of the internal auditory canal. On the right, top image is a coronal CT of the left temporal bone centered at the level of the external auditory canal. And then for our bottom right image, we have a previously performed coronal CT at the level of the kidneys. Our question is, based on the findings, what is the most likely diagnosis, and what additional abnormalities might be expected given the most likely diagnosis? This is in fact a nice representation of branchiotorenal syndrome. I provided several imaging findings from our case as well as an image from the literature that nicely illustrates the pertinent findings that can be found in branchiotorenal syndrome. On the left, we have an excellent example from the literature demonstrating a high-resolution axial image of the CT of the temporal bone at the level of the cochlea, which shows the unwound cochlea with displacement of the middle turn away from the basal turn, as indicated by the white arrow. Middle column top image, we can appreciate on axial CT image a dysmorphic appearance of the ossicular chain with ankylosis of the head of the inguinalveolar joint, as indicated by the green arrow, and horizontal orientation of the dysmorphic long process of the incus, indicated by the red arrow. Middle column bottom image is an axial CT at the level of the eustachian tubes, showing that the right eustachian tube is dilated and patulous in appearance. Top right image is a coronal CT through the left temporal bone, demonstrating an angulated appearance of the external auditory canal. Lastly, the bottom right image is our coronal CT of the abdomen, showing absence of the right kidney. Further history revealed that the patient had evidence of preauricular pits on physical examination, a history of resected branchial cleft cyst in childhood, and a father with reported history of deafness. After seeing our colleagues in ENT and nephrology, the patient was ultimately sent for consultation with the geneticist. Workup revealed a positive mutation of the EYA1 gene. The patient is currently approaching end-stage renal disease and is undergoing workup for possible transplantation. He is currently considering a number of hearing devices to assist with his profound hearing loss. The patient's clinical exam findings, past medical and family history, imaging findings, and genetic analysis are all in keeping with branchiootorenal syndrome. The constellation of findings described with branchiootorenal syndrome was first articulated in the 19th century, but was not defined until the 1970s. It is a rare syndrome that is seen in approximately 1 in 40,000 patients. However, it does represent one of the more common syndromic causes of deafness. The diagnosis of the syndrome is established by the presence of certain diagnostic criteria. An affected individual must have at least 3 major criteria, or 2 major criteria and at least 2 minor criteria, or 1 major criteria and an affected first-degree relative meeting criteria for the syndrome. Major criteria include branchial anomalies, deafness, preauricular pits, and renal anomalies, while minor criteria include external ear anomalies, middle ear anomalies, inner ear anomalies, preauricular tags, facial asymmetry, and abnormalities of the palate. The underlying pathology for branchiootorenal syndrome is still not entirely understood, though it is thought to occur as a result of a developmental abnormality during the 4th through 10th weeks of embryogenesis. The most commonly implicated gene in branchiootorenal syndrome is EYA1 on chromosome 8. The gene is thought to promote cell survival during embryogenesis and is notably expressed by middle and inner ear structures and cells implicated in the development of the genitourinary system. The temporal bone imaging findings that have been described with branchiootorenal syndrome are very wide-ranging and include, among other possible findings, the unwound cochlea, previously described, where there is anterior offset of the hypoplastic apical middle turns away from the basal turn of the cochlea, hypoplasia of the apical turn of the cochlea, deficiency of the medialis, medialization of the facial nerve, vestibular aqueduct enlargement, certain semicircular canal abnormalities such as hypoplasia and dehiscence, a funnel-shaped internal auditory canal, patulous eustachian tubes, and external auditory canal abnormalities such as stenosis or atresia. These CT temporal bone findings are all in addition to the physical exam findings that can be seen with branchiootorenal syndrome, as well as renal anomalies that may be seen on abdominal and pelvic imaging. I thought this case was interesting for a few reasons. One, it is a case of an overall rare syndrome that is not routinely encountered in practice, however, represents one of the most common syndromic causes of hearing loss. As a result, it is certainly a syndrome that neuroimagers should have some familiarity with. Also, While those of us either working at or affiliated in some way with large children's hospitals are certainly accustomed to coming across rare conditions, this was actually an interesting case where the patient presented much later in life and, rather than being imaged at a tertiary children's hospital, happened to present at one of our satellite community centers. It just shows you that you never know what difficult, challenging, interesting cases we may come across, regardless of patient age, demographics, or location that the imaging was performed. Thank you again for tuning in to learn about my case of the day, and thank you again to Dr. Chapman and the committee for allowing me to present at ASHNR 2020. I hope everyone has a great conference. Thanks.
Hi, my name is Dr. Katie Traylor, and I'm an assistant professor of radiology in the Neuroradiology Division at the University of Pittsburgh. I would like to thank Dr. Phil Chapman and the organizing committee for giving me this opportunity to do the case of the day for the American Society of Head and Neck Radiology annual conference. I did the case of the day number 2. So for my case, this was a 56-year-old female with a right-sided oral tongue lesion which had been present for approximately 1 year prior to presentation. The patient had an extensive prior smoking history and quit 5 years prior. The patient continues to drink 3 alcoholic beverages per day. So for the imaging review, first we have the PET-CT image, which on the left is the fused coronal image. Then we have 2 attenuation-corrected images in the center and on the right, corresponding to 2 separate areas within the oral cavity. So this is the lesion of concern along the right oral tongue. It's FDG avid, but this case came to tumor board not for this typical oral cavity cancer. It came because they saw this lesion inferiorly within the right floor of mouth that they thought was the same entity as the FDG avid lesion within the right tongue. So this lesion has no FDG avidity. It's even less than the background on the normal neck portion of the study. So, and if we look really carefully, we even see these rounded lesions within the center portion of the larger devoid FDG lesion. So if we look at the diagnostic CT portion of the PET-CT, again, we have that enhancing lesion along the right tongue. And then we have this well-circumscribed hypodense mass along the right floor of mouth, which is very well circumscribed. And then we have these central rounded, well-circumscribed lesions central within the larger lesion within the right floor of mouth. So these 2 lesions are separate. That's very clear on the diagnostic images. If we look closer, these rounded lesions are at several locations within the larger lesion, and there's several. If we look at the coronal, I can prove it to you. There's even 2 subjacent in the same image. When this was taken out, they took out both. They took out the oral cavity cancer along the right tongue, and then they took out this floor of mouth lesion. We told them right away it was a dermoid because we see these rounded lesions within the central portion of this well-circumscribed hypodense lesion. So that's pretty slam dunk for a dermoid. So when they took it out, this is what the dermoid looked like. Here's the sac, this dark colored thing, with all of these rounded lesions, which is these rounded lesions that we see on the CT. So there's a lot more than we actually see on imaging. It has a sack of marbles or bag of marbles appearance that we always tell our residents. So the answer to this case is an oral cavity squamous cell carcinoma with an incidental floor of mouth dermoid cyst. Now, these are teratomas, which are neoplasms containing multiple tissue types. They're foreign to the part of the body where the lesion arose. They're most commonly dermoid, so we just basically call everything dermoid cyst, but they are dependent on the tissue type. So a dermoid contains ectoderm and mesoderm. It's a congenital lesion. It rarely occurs in the mouth, but when it does, 24% occur in the oral cavity, and 11% of those occur in the floor of mouth. In the oral cavity, the floor of mouth is most common, and this is the sublingual, submental, or the submandibular regions. On imaging, it's very important to tell the surgeon where the cyst is in relation to the myohyoid muscle, and that's for surgical planning. So if it's above the myohyoid muscle, as in our case, it's sublingual, they can do an intraoral approach, and that's preferable because that avoids patient scarring and it also preserves that myohyoid muscle. However, if it's below the myohyoid muscle, they have to do an external surgical approach. So that causes lots of scarring to the patient and can damage the myohyoid muscle. So identification of these intracystic, rounded, floating things and on imaging, this sac of marbles appearance is considered pathognomonic. So these rounded things that we saw in imaging, you can call it right away a dermoid cyst, and that's what we told them at the tumor board. It said that in the report, but they wanted to make sure. So clinically, these are non-tender. They're slow growing. A lot of times the patient doesn't even know they have them until they are imaged for some other reason. But they can rapidly grow during pregnancy. And the problem is if the lesion is large enough or grows fast enough, the patient can have symptoms of dysphagia and odynophagia. And that's when the patient might need these removed. So a lot of times they don't bother anything. They just sit there. This one was taken out just because of the tongue cancer that we found, but they don't necessarily have to be removed. So our patient had a pathology T2N0 squamous cell carcinoma of the right oral cavity. They had a hemiglossectomy. They also had an intraoral resection of this right floor of mouth dermoid, and then they had a selective neck dissection with 0 positive lymph nodes. So I would like to thanks again for inviting me to do a case of the day. I really appreciate it and I'm honored, and I hope you enjoy the rest of the conference. Thank you.
Hello there. I'm delighted to present the case of the day for the vascular category at the 2020 American Society of Head and Neck Radiology meeting. My name is Benjamin Kwan, and I am a neuroradiologist presenting from Queen's University in Canada. Thank you to Dr. Phil Chapman and the programming committee for the opportunity to present. Now on to the case. Case presentation. A 68-year-old female with recent onset bilateral sequential, no light perception vision secondary to presumed giant cell arteritis with markedly elevated ESR and CRP. The patient received IV methylprednisolone. The patient was scheduled for temporal artery biopsy, but the only region with a faint pulse detected was in the right preauricular region, which is not a safe area for biopsy. Scalp vessel wall MR imaging was subsequently ordered. Imaging. On the top row, from left to right, we have 3D T1 fat-saturated black blood images without contrast in the axial, coronal, and sagittal planes. On the bottom row, from left to right, we have the corresponding 3D T1 fat-saturated black blood images with contrast in the axial, coronal, and sagittal planes. For this case of the day, what is the abnormality and diagnosis? Imaging explanation. This case demonstrates giant cell arteritis on scalp vessel wall MRI. Post-contrast, high-resolution 3D T1 fat-saturated black blood images of the scalp vessels demonstrate enhancement of the proximal right superficial temporal artery in the region of palpable pulse, consistent with the diagnosis of giant cell arteritis. Notice also that there is thickening of the artery. Key facts. Giant cell arteritis is a chronic vasculitis of large and medium-sized arteries. The peak incidence is at 70 to 80 years. Clinical findings include headache, temporal artery tenderness on palpation, vision loss, jaw claudication. Early diagnosis and treatment is important to prevent vision loss. Temporal artery biopsy can yield false negatives due to skip lesions and sampling error. It is an invasive procedure. Scalp vessel wall imaging can be a tool to guide biopsy and can be performed for biopsy planning. Thickening and enhancement of the superficial temporal artery are classic findings for giant cell arteritis on scalp vessel wall imaging. Scalp vessel wall imaging can be performed using both 2D and 3D techniques. A recent publication on a 3D vessel wall imaging technique reported a sensitivity of 80% and a specificity of 100%. Remember, scalp vessel wall imaging requires fat saturation as the scalp vessels run in the subcutaneous tissues of the scalp. The advantage of a 3D technique over a 2D technique include multiplanar reformations, which better visualize tortuous segments of the temporal artery. Patient outcome. The patient was treated with prednisone, however, the patient did not have any significant visual recovery. The patient was able to have a consistent diagnosis for giant cell arteritis, even though a biopsy was not obtainable. Take-home message. Scalp vessel wall imaging can be a troubleshooting tool in cases precluded from temporal artery biopsy. Thank you for your attention.
Hello there. We are delighted to present this case of the day to you at the 2020 annual meeting of the American Society of Head and Neck Radiology. And thank you to Dr. Phil Chapman and the ASHNR programming for this opportunity to share this case of the day. My name is Victor Babatunde, a radiology resident at the University of Pennsylvania. I work closely with Dr. Jay Song on this case of the day presentation. The other contributors on this case are Dr. Rob Kurtz from radiology and Dr. Kathleen Montone from pathology, all at the University of Pennsylvania. Now to our case of the day. We have a case prompt of a 25-year-old male who comes into our emergency department with 2 weeks of left eye proptosis and chronic nasal congestion. Besides the proptosis of the left eye and blurry vision, his physical exam was normal. Vital signs were also normal. CT and MR imaging were obtained for further evaluation of this patient's symptoms. Here we begin with the images. From left to right, we see the first panel consisting of non-contrast CT head images with representative axial and coronal slices shown. Then the middle column shows T2 weighted MR images of the head in axial and coronal planes. The third column displays unenhanced and enhanced T1 weighted images both in the coronal plane. For this case of the day, what is the diagnosis based on the images provided? What is going on with this gentleman's left eye? This case beautifully illustrates allergic fungal sinusitis. Non-contrast CT shows expansion of multiple sinuses with smooth osseous remodeling and thinning of the sinus wall, indicated by the yellow arrow. CT also shows hyperdense material filling the paranasal sinuses, here with complete opacification, indicated by the red arrow on the axial CT. The expanded sinuses demonstrate mass effect superiorly into the brain and medially into the orbits. But I want to highlight that there does not seem to be intracranial or intraorbital invasion. For example, there is no intraorbital fat stranding. Now let's look at the MR. Here, the axial T2 weighted sequence at the level of the coronal radiata shows intracranial extent due to markedly expanded frontal sinuses filled with this material. We see markedly low T2 signal, which correlates with the hyperdense material on CT, as indicated by the red arrow. We know this T2 hypointensity does not represent air, given the CT appearance. Again, there are no features of intracranial parenchymal invasion, no brain edema is seen. These classic features of high-density sinus content that shows T2 hypointense signal on MR are consistent with fungal elements, and the absence of tissue invasion, despite the extent of sinus expansion, indicates this is non-invasive. I'd like to highlight this is an otherwise healthy 25-year-old gentleman, and he is immunocompetent. For management, he underwent functional endoscopic sinus surgery, and courtesy of pathology images from Dr. Montone, I'm happy to share with you H&E stains showing eosinophilic mucin and a GMS stain confirming fungal elements. His diagnosis is consistent with allergic fungal sinusitis. To diagnose allergic fungal sinusitis, consider these helpful clues. First, allergic fungal sinusitis is considered a severe form of chronic rhinosinusitis, which commonly affects younger adults. Affected patients may have a concurrent history of atopy, including asthma and allergic rhinitis. On imaging, it most often involves multiple sinuses. On CT, you will see hyperdense contents filling and expanding the sinuses. Chronic changes of allergic fungal sinusitis also show smooth chronic osseous remodeling without overt bony destruction or erosions. On MR, the hyperdense fungal elements on CT will correlate with low T2 signal. There's usually variable T1 signal intensity depending on the amount of protein and water content. Rim enhancement of the inflamed sinonasal mucosa is typically present. The differential in this case includes sinonasal polyposis, which classically presents as polypoid masses involving the nasal cavity. Fungal mycetoma would commonly appear as one ossified non-expanded sinus with increased density with or without matrix calcifications. Sinonasal non-Hodgkin lymphoma typically appear homogeneous on CT and MR with homogeneous enhancement. To conclude our case, following surgery, the patient's symptoms substantially improved, is currently on low-dose steroid therapy with plans for aeroallergen immunotherapy. Thank you for listening to our case of the day.
Hello, everyone. Thanks, Dr. Chapman, for giving me the opportunity to present the case of the day at the virtual annual meeting of American Society of Head and Neck Radiology. This is the case of a 62-year-old man who presents with right-sided conductive hearing loss. Figure A is the axial CT slice at the level of temporal bone, which demonstrate irregular area of bone erosion and destruction with a moth-eaten pattern in the right petrous bone arising at the upper portion of jugular bulb and extending anteriorly up to the wall of the carotid canal, and also a small amount of soft tissue seen extending in the right medullary cavity. Figure B is an axial fat-saturated T2 weighted image with mass demonstrating slightly hyperintense signal, and you can also see there is trapped fluid within the right petrous apex cell. Figure C is a post-contrast fat-saturated image which demonstrates intense enhancement in the mass. Figure D and E represents conventional angiography projections with catheter tipped in the right common carotid artery and in the right external carotid artery, and the mass demonstrate intense tumor blush which is being supplied by the branches of external carotid artery. The combination of these findings of permeative lesion with soft tissue in the right medullary cavity at the level of jugular foramen with intense enhancement and intense tumor blush on angiography is consistent with a paraganglioma, and in this case, a glomus jugulare paraganglioma. Figure F and G are axial and coronal SPECT perfusion images of the brain performed during carotid blue nucleation test, which is performed as a part of preoperative workup to determine the collateral circulation in the brain. The carotid blue nucleation test is performed to assess collateral circulation and cerebral vascular capacity or reserve in patients who require temporary or permanent sacrifice of one of the carotid arteries. The temporary carotid blue nucleation test was developed to determine whether a patient will be able to tolerate a carotid artery occlusion procedure or not, and is commonly performed in head and neck tumors, including paraganglioma and head and neck cancers, which invades the carotid artery, and in cases of large cerebral aneurysm. Before a carotid blue nucleation test is performed, a conventional angiography of bilateral carotids and vertebral artery is performed to establish anatomic collateral circulation of the sulcus of Willis. A balloon catheter is subsequently placed into the target internal carotid artery, followed by intravenous injection of perfusion radiotracer, and then the SPECT images are required to assess the collateral circulation and to determine the risk of ischemia and infarction after potential carotid sacrifice. In this case, you can clearly see on the axial images there is significant asymmetric decreased perfusion in the right ACA and MCA territory on the right cerebral hemisphere, and similarly on coronal perfusion images you can see this asymmetric decreased perfusion in the right cerebral hemisphere, suggestive of hemodynamic compromise and inadequate collaterals, and increased risk of infarction if the right internal carotid artery is sacrificed during surgery. Fortunately, this patient underwent successful resection of tumor without the need of carotid sacrifice and has full, uneventful post-op recovery. Thanks everyone for your time.